Hello, friends. Today we are going to read the 95th chapter of the John Murtagh's General Practice book. So, this chapter is about the lower abdominal and pelvic pain in women. Let's proceed. Pain in the lower abdomen and pelvis is one of the most frequent symptoms experienced by women. The diagnostic approach requires a wide variety of consultative skills, especially when the pain is chronic. The examination of chronic abdominal pain has been simplified by sensitive serum pregnancy tests, ultrasound, and laparoscopy. However, an accurate history and examination for all types of pain will generally pinpoint the diagnosis. The ever present problem of pelvic inflammatory disease, a significant cause of infertility in women, demands an early diagnosis and appropriate management. Then there are listed some key facts and checkpoints. Let's read them out one by one. A distinction has to be made between acute, chronic, and recurrent pain. Ectopic pregnancy remains a potentially lethal condition, and its diagnosis still requires a high index of suspicion. Sudden, sharp pain in the pelvis that becomes more generalized indicates rupture of an ectopic pregnancy or an ovarian cyst. Recurrent, sharp, self-limiting pain indicates a ruptured Graafian follicle. Recurrent pain related to menstruation is typical of dysmenorrhea and endometriosis. Endometriosis affects 1 in 9 women. On average, it takes 6.5 years for endometriosis to be diagnosed. The principal efferent pathway of the pelvic viscera arises from T10 to T12, L1, and S2 to 4. Thus, disorders of the bladder, rectum, lower uterus, cervix, and upper vagina can refer pain to the lower back, buttocks, and posterior thigh. Chronic or persistent pelvic pain is a complex neuromuscular psychosocial disorder and estimated to affect 15 to 20% of women. Next, we'll approach a diagnostic approach. A summary of the diagnostic strategy model indicates the probability diagnosis. There are 4 most probable diagnoses. They are the primary dysmenorrhea, Mittelsmers, pelvic or abdominal adhesions, endometriosis. Then, in a woman who is presenting with low abdominal and pelvic pain, the serious diagnostic disorders that are mentioned that we should not be missing are the ectopic pregnancy, neoplasia, severe infections, acute appendicitis, and internal iliac claudication. Those 5. When we consider the neoplasia, it mainly focuses on ovarian cancer, cervical and uterine cancers, and other pelvic structures. Then the severe infections mean the pelvic inflammatory disease or pelvic abscesses. And then there are listed diagnoses that are mentioned or categorized as pitfalls or orphan diagnoses that are often missed. Those are endometriosis or adenomyosis, torsion of ovary or pedunculated fibroid, constipation, fecal impaction, irritable bowel syndrome, malpositioned intrauterine device, pudendal neuralgia, then referred pain referred to the pelvis from appendicitis, cholecystitis, diverticulitis, and urinary tract disorders. Then other diagnoses are the transvaginal mesh complications, ovarian vein incompetence, or pelvic congestion syndrome. Then other diagnoses that we have to consider are depression, drugs, spinal dysfunction leading to referred pain, and urinary tract infection. So when we consider about the probability diagnosis, the commonest causes are primary dysmenorrhea, pain from ruptured Graafian follicle, endometriosis, and adhesions. Those four are the probability diagnoses. In many instances of pain, no diagnosis is made as no pathological cause can be found. Then, considering the serious disorders not to be missed, the potential lethal problem of a ruptured ectopic pregnancy must not be missed. Hence, the axiom, be ectopic minded. Pelvic inflammatory disease can be overlooked, especially if chronic, and requires early diagnosis and aggressive management. Neoplasia also must be considered, especially malignancy of the pelvic structures, including the silent ovarian cancer. Then, under pitfalls, the several disorders are very difficult to diagnose, and these include hemorrhage into the ovary or a cyst, torsion of the ovary or pedunculated fibroid. Endometriosis may be missed, so it is important to be familiar with its symptoms. Chronic constipation may be a trap. Other two important conditions to consider are urinary tract infection and spinal dysfunction. Just as disorders of the pelvic organs, such as endometriosis and pelvic inflammatory disease, they can refer pain into the lower back and buttocks. So can disorders of the lumbosacral spine cause referred pain to the lower abdomen and groin. Then let's move on to psychogenic considerations. These are extremely relevant. Problems in the patient's social, marital, or sexual relationships should be evaluated, especially in the assessment of chronic pain. Up to 50% of patients with persistent pelvic pain have a history of physical, sexual, and emotional abuse or trauma, and about one-third have positive screening result for post-traumatic stress disorder. Now let's move on to the clinical approach. In the history, the pain history should be linked with the menstrual cycle and the possibility of an early pregnancy. Inquire about dyspareunia dyspareunia on entry or on deep penetration and contraceptive use. Note obstetric and past surgical histories. The severity of the pain can be assessed as follows. How it interferes with the daily activity, the number of days off work or study, the resulting in confinement to bed. In this way, the pain can be classified objectively as mild, moderate, or severe. The typical pain pattern in relation to the menstruation is shown in this graph. When we consider the menstruation, the pain usually occurs few days earlier in endometriosis, peaks around the onset of menstruation, lasts throughout the menstruation, and gradually decline, but the pain usually lasts even after the menstruation stops. Then when we consider the secondary dysmenorrhea, the pain occurs before the onset of menstruation and peaks around the initial few days of menstruation, but it weans off and never persists after the end of menstruation. Then the pain that comes with primary dysmenorrhea quickly occurs, more acute onset with the onset of menstruation and peaks and then gradually wanes off, usually last about 1 to 2 days only. Then the pain occurs in the mid-cycle is due to the distension of the ovarian capsule causing pain or the pain because of the ovulation. So those are the history that we have to consider. Then let's move on to examination. Then use the traditional abdominal and pelvic examination to identify the site of tenderness and rebound tenderness and any abdominal or pelvic masses. When clinically indicated, the pelvis should be examined by speculum and by manual palpation. Instrumental vaginal examinations are unlikely to be indicated in young women who are not yet sexually active. However, sexual experience does not automatically mean that the internal or instrumental examination is either necessary or acceptable to a young person. Proper assessment can be difficult if the patient is anticipating pain, if there is abdominal scarring or obesity, or if extreme tenderness is present. It's therefore important to give a thorough explanation, give permission to end the examination at any time, and obtain consent to proceed. Offer a chaperone or support person to be present. Then let's move on to investigations. Investigations may be selected from full blood count, ESR or CRP, urine microscopy and culture, endocervical and vaginal swabs for chlamydia, gonorrhea, PCR, serum beta-HCG urinary beta-HCG test. They can be negative in the presence of an ectopic pregnancy. Then imaging. The transvaginal ultrasound indicated for to define a gestation sac, for pelvic pain, for a palpable pelvic or lower abdominal mass. Laparoscopy may be indicated if the history and examination are suggestive of ectopic pregnancy and ultrasound fails to confirm an intrauterine pregnancy. Okay, let's move on to description about acute pain. The cause of acute pain are summarized in table. I'll read it out later. The patient is usually young, 20 to 30 years old, sexually active and distressed by the pain, and should be considered foremost to have a bleeding ectopic pregnancy. So young patient, sexually active, distressed by the pain, they should be considered to be having an ectopic pregnancy unless proven otherwise. Important differential diagnoses that should be included are acute pelvic inflammatory disease, rupture or torsion of an ovarian cyst, and acute appendicitis. Cases of acute ruptured ectopics are easier to diagnose in the presence of circulatory collapse. So the causes of lower abdominal pain and pelvic pain in women include the genital causes, non-genital causes, and functional causes. The genital causes are the pelvic inflammatory disease, ovarian torsion, ovarian cyst rupture or hemorrhage or torsion, threatened or incomplete abortion, ectopic pregnancy, uterine fibroid with degeneration or torsion, malpositioned intrauterine device, endometriosis, ruptured or bleeding endometrioma. Non-genital causes are acute appendicitis, bowel obstruction, urinary tract infection or cystitis, then urinary colic due to calculus, inflammatory bowel disease, diverticulitis. The functional causes are the primary dysmenorrhea and irritable bowel syndrome. Let's move on to ectopic pregnancy. Ectopic pregnancy occurs approximately once in every 100 clinically recognized pregnancies. So the frequency is 1 in 100. If ruptured, it can be rapid fatal condition, so we have to be ectopic minded. It's the commonest cause of intraperitoneal hemorrhage. There's usually a history of missed period, but a normal menstrual history may be obtained in some instances. The clinical features of a ruptured ectopic: average patient in mid-20s, the first pregnancy in 1/3 of patients, patient at risk of previous ectopic pregnancy, previous pelvic inflammatory disease, previous abdominal or pelvic surgery, especially sterilization reversal, endometriosis, in vitro fertilization. So those women are at higher risk of having a possibility of an ectopic pregnancy. Pre-rupture symptoms include pregnancy of unknown location, cramping pains in one or other iliac fossa, vaginal bleeding. With rupture, it causes excruciating pain and circulatory collapse. In 10 to 15%, there is no abnormal bleeding. Then the pain may radiate to rectum or vagina or leg. Then there can be signs of pregnancy like enlarged breasts or uterus, but usually they may not be present because this occurs very early stages of the pregnancy. Then the examination, there can be deep tenderness in iliac fossa. With vaginal examination, the tenderness on bimanual pelvic examination, pain on cervical provocation, like the cervical motion tenderness. Then palpable adnexial masses, soft cervix. Those are the findings of the vaginal examination. Tender on bimanual pelvic examination or cervical excitation. And then palpable adnexial masses and soft cervix. Then there can be bleeding, the prune juice appearance. Then temperature and pulse usually normal during the early stages, but with the onset of rupture of the ectopic pregnancy, the circulatory collapse occurs, whereby the BP drops. The diagnosis. It's possible to diagnose an ectopic pregnancy at a very early stage of pregnancy. Urine pregnancy test can be positive in most ectopic pregnancies, but however, serum beta-HCG assay may need serial quantitative test to distinguish an ectopic from a normal intrauterine pregnancy. If serum beta-HCG is more than 2000 international units per liter, an intrauterine pregnancy should be visible on vaginal ultrasound. If the uterus is empty, an ectopic is more likely. If serum beta-HCG is less than 200 intrauterines per liter, repeat every second day to see whether it's increasing normally as expected in normal intrauterine pregnancy. Usually it doubles. Transvaginal ultrasound can diagnose at 5 to 6 weeks. The ultrasound scan criteria are the empty uterus, tubal sac, then fluid in cul-de-sac. Laparoscopy is the definitive diagnostic procedure. So to diagnose ectopic pregnancy, we can do beta-HCG assays, transvaginal ultrasound, and laparoscopy. How do we manage? The possible options are surgery, either medical or expectant management. In a small number of carefully selected cases, the medical or expectant management can be done. The medical management involves injecting intramuscular methotrexate, while surgery involves salpingectomy or salpingostomy. Surgery should be performed laparoscopically wherever possible. Rupture with blood loss, usually 7% of cases, they demand urgent surgery. So after the surgery, most 60 to 65% are managed very successfully. And then, but however, they carry a subsequent risk of ectopic pregnancy that is about 10 to 15%. That's all about ectopic pregnancies. Then let's move on to pelvic inflammatory disease. Pelvic inflammatory disease is a syndrome of inflammatory disorders of the female upper genital tract, including endometritis, salpingitis, tubo-ovarian abscesses, and pelvic peritonitis. Pelvic inflammatory disease is most commonly sexually acquired, although non-sexually acquired pelvic inflammatory diseases may result from gynecological procedures such as intrauterine device insertion. Pelvic inflammatory disease may be either acute, which causes sudden severe symptoms, or chronic, with milder symptoms and more gradual onset. A high index of suspicion is required in young, sexually active women who present with new onset pelvic pain. Recent partner change is an important risk factor. There are serious consequences of pelvic inflammatory disease. Those are the tubal factor infertility, which accounts for 20%, chronic pelvic pain seen in 20%, and ectopic pregnancy that's observed in 10%. The risk of complications increases significantly with repeated episodes of pelvic inflammatory disease. Then the clinical features of acute pelvic inflammatory disease include fever. Usually it's equal to or more than 37 degrees Celsius. Moderate to severe lower abdominal pain, nausea, vomiting. In chronic pelvic inflammatory disease, there is ache in the lower abdomen, lower back, and mild lower abdominal pain. Then both in acute and chronic pelvic inflammatory disease, patients have dyspareunia, vaginal bleeding, either postcoital, intermenstrual or heavy menstrual bleeding. Then abnormal or offensive purulent vaginal discharge. Then painful or frequent urination. What are the things that we are going to look in during the examination? In acute pelvic inflammatory disease, there may be lower abdominal tenderness and rigidity. Pelvic examination in acute PID, pelvic inflammatory disease, there is unusual vaginal warmth, cervical motion tenderness, and adnexial tenderness. Speculum examination usually reveals a red, inflamed cervix and a purulent discharge. The causes are polymicrobial. No pathogen is identified in most cases. That is, in 70% of cases, no pathogen is identified. Then there can be sexually transmitted infections that are responsible for pelvic inflammatory disease, and those are the chlamydia trachomatis, which is most common, Neisseria gonorrhoeae, Mycoplasma genitalium. Then vaginal flora is another cause. Changes in the cervico-vaginal environment may allow vaginal bacteria to ascend to the upper genital tract, which is considered another cause. How do we diagnose? The diagnosis is clinical and may be difficult, as signs and symptoms can be nonspecific and correlate poorly with the extent of inflammation. The most common symptoms are vaginal discharge, lower abdominal pain, and dyspareunia. The most common signs are adnexial tenderness and cervical motion tenderness. Rapid response to antibiotic treatment is highly predictive of pelvic inflammatory disease. The presence of sexually transmitted infections support the diagnosis. Then, the investigations. Endocervical swab for nucleic acid amplification test or PCR for Neisseria gonorrhoeae, Chlamydia trachomatis, and Mycobacterium genitalium. Then endocervical swab for culture, blood culture, especially if the patient is febrile, pelvic ultrasound to detect alternative causes of pain. Treatment. If it's a sexually acquired infection, begin treatment immediately with a provisional diagnosis without waiting for the test results. For mild to moderate infection, we can treat as outpatients. Usually ceftriaxone 500 mg, either given intramuscular or intravenous as a single dose for gonorrhea, and metronidazole 400 mg twice a day for 14 days, and doxycycline 100 mg twice a day for 14 days can be given. If Mycobacterium genitalum confirmed, prescribe 2 weeks of moxifloxacin 400 mg daily for 14 days. If patient is pregnant or breastfeeding, instead of doxycycline, use azithromycin 1 mg as a single dose and repeat after 1 week. Then treatment of post-procedural pelvic pain. For mild infection, use amoxicillin plus clavulanate for 14 days. If hypersensitive to penicillin, use trimethoprim sulfamethoxazole combination and metronidazole for 14 days. Consider switching to intravenous therapy if no response is observed after 72 hours. Then further management, you have to advise the patient to avoid sexual intercourse for a week following treatment or until symptoms resolve. Intrauterine devices should be removed if there is no response to treatment in 48 to 72 hours. A new intrauterine device can be inserted once the infection has resolved. Current sexual partners should be treated with agents effective against chlamydia trachomatis and Neisseria gonorrhoeae, irrespective of the test results. If a sexually transmitted pathogen is identified, perform a test of cure 1 month after starting treatment. So these are the points that we should counsel the patient after the treatment. I'll brief them again. We are to advise to avoid sexual intercourse for a week following treatment or until the symptoms resolve. Intrauterine devices should be removed if there's no response within 48 to 72 hours and can be reinserted. A new device can be reinserted once the infection has resolved. Then sexual partners are better treated for chlamydia and gonorrhea. If a sexually transmitted pathogen is identified, you have to perform a test of cure after 1 month of starting treatment. Then ruptured ovarian follicle. When a Graafian follicle ruptures, a small amount of blood mixed with follicular fluid is usually released into the pouch of Douglas. This may cause peritonism, which is different from the unilateral pain experienced just before the ovulation due to distension of the ovarian capsule. So if you remember the graph that we had a look in the beginning of this chapter, with the ovulation, there were two peaks of pain. One is the pain because of the ovulation, and the other one is because of the distension of the ovarian capsule. So the pain that occurs due to the distension of the ovarian capsule is usually unilateral and it occurs before the ovulation. And the peritonism or the Graafian follicular rupture that causes this ovulation pain, Michelsman's pain, that is usually occurs in the pouch of Douglas. So it's not unilateral. So the clinical features, however, the pain occurs in the mid-cycle. Then deep pain in one or other iliac foci, it's usually common in the right side, often described as horse kick pain. Pain tends to move centrally and heavy feelings in pelvis, which is relieved by sitting or supporting the lower abdomen. Pain lasts for a few minutes to hours, usually 5 hours. The patient is otherwise perfectly well. Sometimes it may mimic possibility of acute appendicitis. Management is usually the explanation and reassurance with simple analgesics like aspirin or paracetamol, then hot water bottled comfort if pain is very severe. Then let's move on to ovarian tumors. Benign ovarian tumors, particularly ovarian cyst, may be asymptomatic but will cause pain if complicated. They are common in women under 50 years of age. Ovarian cysts are best defined by transvaginal ultrasound, which can identify whether hemorrhage has occurred inside or outside the cyst. The symptoms of ovarian tumors are usually the pain that occurs with the torsion or hemorrhage. Then pressure symptoms can also occur like the bloating, difficulty emptying the bladder or bowel. Let's discuss a bit about ruptured ovarian cyst. The cysts tend to rupture just prior to ovulation or following the coitus. The clinical features are patient usually 15 to 25 years of age, sudden onset of pain in one or other iliac fossa, may be associated with nausea or vomiting, and no systemic signs. Pain usually settles within a few hours. Signs are the tenderness and guarding in the iliac fossa. Then in per rectal examination, there can be tenderness in the rectovaginal pouch. Investigation of choice is usually the transvaginal ultrasound. How do we manage? We have to give appropriate explanation and reassurance. The conservative management, if the cyst is simple, an ultrasound appearance and it's less than 4 centimeters. If there's internal hemorrhage and if with minimal pain. Cysts need vaginal drainage by ultrasonography for a simple or large cyst. Then the laparoscopic surgery is the option for complex cysts, large cysts, or if there's any external bleeding. Acute torsion of ovarian cyst. Torsions are mainly from dermoid cyst, and when the right-sided, may be difficult to distinguish from acute pelvic appendicitis. The clinical features of acute torsion of ovarian cyst include severe cramping lower abdominal pain, diffuse pain, pain may radiate to the flank, back, or thigh, repeated vomiting, exquisite pelvic tenderness, patient looks ill. The signs: a smooth, rounded, mobile mass, palpable in the abdomen, maybe tenderness and guarding over the mass, especially if leakage. Then diagnosed by pelvic ultrasound, the treatment is usually laparoscopic cystectomy. Then let's move on to discuss about the malignant ovarian tumors. Ovarian cancer has an incidence of 10 cases per 10,000 women per year and accounts for 5% of all cancers in women and 20% of all gynecological cancers. It is responsible for more gynecological cancer deaths because the tumor is often well advanced at the time of clinical presentation. Earlier discovery may sometimes be made on routine examination or because of investigation of non-specific pelvic symptoms. Ovarian cancer tends to remain asymptomatic for a long period. No age group is spared, but it becomes progressively more common after the 45 years of age. Peak incidence is 60 to 65 years. Risk factors are age, family history, nulliparity, BRCA1 and BRCA2 gene mutations, the BRCA1 and 2 mutations, Ashkenazi Jewish ancestry. Then the protective factors are the use of combined oral contraceptive pill and pregnancy. The clinical features of ovarian malignancy are constitutional symptoms like fatigue, anorexia, ache or discomfort in lower abdomen or pelvis, abdominal bloating and fullness, gastrointestinal dysfunction like epigastric discomfort, diarrhea, constipation, or wind, sensation of pelvic heaviness, genitourinary symptoms like frequency, urgency, or prolapse. It may or may not be associated with abdominal uterine bleeding. Postmenopausal bleeding, dyspareunia and or dysmenorrhea, which is seen in 10 to 20%, may or may not associate with weight loss. A bimanual examination assists diagnosis. Look for masses, ascites, and pleural effusion. A pelvic mass plus ascites usually indicates ovarian cancer, but occasionally may be caused by a benign ovarian fibroma, which is Meiggs syndrome. It's a triad of benign ovarian tumor, ascites, and pleural effusion. Any ovary that is easily palpable is usually abnormal. Normal ovary becomes rarely larger. Diagnosis is pelvic ultrasound with transvaginal abdominal, pelvic ultrasound with transvaginal and transabdominal waves. Tumor markers such as CA125, beta HCG, and human epidermis protein 4, HE4, and alpha fetoprotein should be measured only if the ultrasound raises suspicion of a malignancy. Refer urgently to gynecologist. Treatment is usually laparoscopy plus or minus adjuvant chemotherapy. Next part is about dysmenorrhea. We'll read it the next day, friends. Thank you for listening. Bye.